and thank you for coming. My name is Hugo Dominguez Malagon, from the National Cancer Institute in Mexico City. My colleague is Dr. Katia Chan GUZMAN, and both are going to present an issue that we think is very interesting. We all know that electron microscopy has to have a very special process, and it's seems like research using electron microscopy and clinical medicine, clinical pathology, or diagnostic pathology is going in two different directions. And we all know that the tissue for electron microscopy has to be processed with that purpose. And if you don't do that, you won't see things for the diagnostic purposes. So we started working with wet tissue, formalin fixed. It has to be wet. But the question is the paraffin embedded tissue good enough for electron microscopic studies? And can you do retrospective studies in formalin fixed tissue, like you do immunohistochemistry and sometimes molecules for the same purpose? So we gathered some cases, a series of cases, and compare the wet tissue for the formalin fixed tissue with glutaraldehyde tissue. So these are the results of our research in Mexico. So I'm going to leave the microphone to Dr. Katia Chan.
Thank you for the presentation. So I'm going to start with this study. The doctor said, is the formalin fixed and paraffin embedded tissue good enough for diagnosis for studies of electron microscopy of tumors? This is a comparative study versus the wet tissue. So as an introduction, the transmission electron microscopy can still provide us very valuable information, especially in difficult tumor cases. It's well known that the formalin fixed and paraffin embedded tissue, the FFPE samples, have been always considered inferior to wet tissue, and this is because of the artifacts. So we have the next situation. For example, when we face with a diagnostic challenge on light microscopy, usually, particularly in cases like second opinion consultations, or in small specimens like biopsies, or even in store cases, we only have the slides and the paraffin blocks. So this is where the targeted sampling of the FFPE processes becomes very unviable. So we have an example. Another problematic is the tumor heterogeneity. For example, we have this rich peritoneal tumor, and these lovely areas corresponds to a well-differentiated liposarcoma. But in these other areas are about a differentiation this case, this is a peripheral nerve sheath tumor. So with the processing of the FFPE, we have the ability to select the desired area. So, but first of all, we need to clarify some concepts. This was our research question. Is the FFPE good enough to make to diagnostic utility? So we took the diagnostic utility as the capacity to the TEM studies to diagnose tumor. And we have these two groups, the wet tissue and the FFPE tissue. And we use as a reference standard the histopathological reports confirming this tumor diagnosis. And this is because given the nature of the cases where this study was conducted, it is impossible to control all the initial fixation in the tumors. So this was a retrospective and comparative study conducted to 2014 to 2023, and it was performed in the National Cancer Institute of Mexico, and we collected a total of 746 cases. And our inclusion criteria was the available histopathological and electron microscopy reports and the clinical data available in the system. Our exclusion criteria was all the non-neoplastic pathology or not available histopathological reports. And for the results, we obtained 476 cases for the wet tissue, and for the FFPE was a total of 270 cases. So for the tissue preparation, in the wet tissue, we initiate with the fixation in a dual aldehyde, this case in a 2.5% of crude aldehyde and 10% of formaldehyde. The post fixation with 2% of osmium tetroxide, the dehydrate, and finally with the embedded in epoxy resin. And for the FFPI, we start with the selection of the H&E slides, the dewashing or hiding, the rehydratation with grade ethanol, the fixation with osmium tetroxide, and finally with the embedded in the spore. Okay, so for the initial evaluation of the tissue preservations, this is an important step in all the processing because we were able to discriminate all the cases, all the tumor cases without an optimal preservation. This is the same example, but the same tumor is a fibroblastic tumor. This is from a wet tissue, and this other one is for FFPE. So we can observe that actually these cells are well preserved comparing to the wet tissue. For the results, the most of the cases were located in the soft tissues, and consequently, the most frequent lineage in this study was the mesenchymal, followed by epithelial. So, for the evaluation of the structural preservation, we have these examples. It's always the wet tissue is always gonna have a superior preservation, but for the FFP cases, the preservation is more valuable. We have this example. All the top images are for wet tissue, and these ones are for FFP. So we have a mesothelioma, we preserve all the microbiome on the surface. And for the FFP, we can see some artifacts, but it still retains some key diagnostic features that may lead us to perform the adequate diagnosis. So this was an example of an acceptable preservation. The second case is the same chondroblastoma. For the FFP, we can observe that the artifacts are more prominent because of the extraction of the lipids and the glycogens, but actually shows a better contrast comparing to the wet tissue. The least frequent finding was this, and we have a serious ovarian cystadenoma, and we can observe that all the surface structures of the cytoplasmic nucleus are well preserved. But for the FFPA, practically all the tissue is destroyed. We can maybe only see some cilia here, but the artifacts are more prominent. So the artifacts are undeniable in the FFP specimens. So we have this last one, example of the cystadenoma, and the most frequent artifacts in these cases were the loss of all the cell surface details. Another important was the cytoplasmic clarity because of the extraction of glycogen, lipids, and finally, another artifact is the expansion of the extracellular spaces that may appear artificially enlarged. So to calculate the diagnostic utility, we using the following concepts. We calculate the sensitivity, the specificity for two groups. So the concept of sensitivity in these cases is the probability that the EM study is valid for diagnosis neoplasms in affected patients. So the sensitivity for the wet tissue was 88%, and for the FFPE was 87%. So with this sensitivity, the Fisher factors was calculated, and we obtained a value of P of 0.0548. So, but what does it mean this? We use the confidence interval was about 96%, and we can maybe traduce this information like there is no significant difference between the diagnosis in FFPE and wet tissues in tumor cases. To summarize all the benefits of the FFPE over the wet tissue, we have the targeted sampling, reduce the tumor heterogeneity, and the possibility to use in specimens where all the tissue has already embedded, like the biopsy specimens. Another advantage is the possibility to perform these ultrastructural studies in retrospective cases, in second opinion consultations, and this open the barrier of the tissue fixation, because in the wet tissue it's impossible to perform these ultrastructural studies because all the tissue has already embedded. And finally, another advantage of the processing of FFPE is we are able to perform these ultrastructural studies in in tumors where the initial fixation was in any hospital, because the standard fixation is in formalin. And additionally, we have the possibility to perform all the ancillary studies like immunohistochemistry or molecular studies in the same block. But we must be realistic. The processing of the FFPE is an alternative, but it's not a replacement. For example, when the imaging resolution is mandatory for the diagnosis, we must know diagnose in this tissue. And in other cases, when the initial fixation was suboptimal, it's impossible to do an adequate diagnosis. And well, the most causes of error in this study was the initial suboptimal initial fixation, but also errors in the sampling tumor, or cases with extensive necrosis. In this chart, we can see all the pros in these two groups. For diagnostic accuracy, the wet tissue is always it's gonna be always the best option. But for small specimens like biopsy, the FFPE is an excellent option. And for retrospective cases or in second opinion consultations, the FFPE is a good option. For the second opinion consultations, as I previously said, we have the contrast that the tissue preservation is more valuable, and it's not always possible to control this initial preservation. So the conclusion, the use of FFPE is an alternative because of the preservation of some key features in some tumors. And the major advantage to use this is the targeted sampling, eliminate the dependency to fresh or wet tissue, and it's ideal to perform in retrospective cases. Well, Dr. Baltifora says in the past that the electron microscopy was for sale. So with this study, we can demonstrate that we are the electron microscopy. It provides very valuable information.
And when Dr. Chan and myself are presenting a series of cases to prove the statements we made here, all of them were either final diagnosis, or were a complementary diagnosis for the already seen cases, clinical cases. So she's going to present, Dr. Chan is going to present case number 1, please.
So this is the first case, and this is a 17-year-old male, and we received a core biopsy of a lesion in the superficial soft tissues of the right leg. So this patient has a previous important history. 6 months ago was diagnosed with a lung adenocarcinoma and an invasive mucinous, and this lesion was completely resected, and NGS profile show a EGFR exon 90 deletion. And this patient has a very important previous family history. He has a great-grandmother and a female cousin, both deceased because of a brain tumor. He has one uncle and one cousin with osteosarcoma. And he has another uncle with double primary, an astrocytoma and liposarcoma. So while these findings are highly suggestive of a synomatic association, this was the core biopsy, and we can observe these infiltrating neoplasms and in disposing fascicles. At higher modifications, the cells are fusocellular, and other cells are with this rhabdoid appearance, and the nucleus is displaced to the periphery, and the cytoplasm is dense eosinophilic. But we were not able to see any other structure. We do not identify any necrosis or mitosis. And this was the initial panel. This tumor was negative for cytokeratins, and given the location in distal extremity in a young patient, we must rule out the possibility of a subpart alveolar sarcoma, but the TF3 was negative. Another possibility was a picoma because of this appearance, but the melanate and S100 was also negative. We can rule out a possibility of a neural tumor. This was negative for S100 and NSE, and the Ki-67 was very low mitotic activity. Low. It's important to say that we didn't perform a muscular marker, but we decided to perform this ultrastructural study. So in this so we can observe these large polygonal cells surrounded by these base lamina, and the cytoplasm presents these glycogen particles, and we were able to see these C-bands with these parallel fibroblasts. Find this very suggestive of skeletal muscle differentiation. In this case, given we didn't found any mitosis activity or necrosis in the previous biopsy, these findings were highly suggestive of a rhabdomyoma. That's why we decided to complete the immunohistochemical panel in the biopsy, and well, this was highly positive for desmin and with nuclear expression on MYOT1. A few days later, the same patient presents another lesion in the chest wall. The lesion was low-grade, were circumscribed, and given the previous history of lung adenocarcinoma, the first possibility was about a metastasis. So macroscopy, this lesion is low-grade, tanned, with rubbery consistency. And the histological features show this neoplasm with this solid powder. The cells are large. The with this random appearance, and no mitosis or necrosis was identified. These features are consistent with our rhabdomyoma. I'm sorry, this presentation is overlooked, but we actually added MSA, which was highly positive. So till this, the bone lesions in the chest wall and in the thigh were consistent with our rhabdomyoma adult type. The Department of Genetics confirmed that this patient was carrier of a pathogenic TP53 variant, confirming the Lee-Fraumeni syndrome. Well, the final diagnosis for this patient was the lung adenocarcinoma and the multifocal adult rhabdomyoma. With this information, we decided to add TP53 and who was mutated. We can see this overexpression in the nucleus cells. So moving to the literature review, these entities, the rhabdomyomas, represent only the 2% of all the striated muscle tumors. And we have two subtypes, the cardiac and the extracardiac. The fetal, the genital, and the adult type. This last one is predominantly affect hidden neck area or in adult patients. And regarding to this Lee-Fraumeni syndrome, this is an autosomal dominant disorder, and it's caused because of the pathogenic or live pathogenic TP53 variants. And well, this entity confers a lifelong risk of developing multiple primary tumors. These are the most frequent primary malignancies in this syndrome: breast, soft tissues, brain, adrenal glands, and bone. And in young patients, especially children and adolescents, the sarcomas are the most frequent malignancy associated. And the rhabdomyosarcoma is the most frequent lesion, following by osteosarcoma, liposarcoma, and leiomyosarcoma. So I'm sorry for the inconveniences in this slide. This was an article who talks about the multifocal adult rhabdomyomas. These entities are actually, these case reports are in the hidden neck region, and the most frequent are in the floor of the mouth and in the oropharynx. So, this is another case report with a patient of 70 years, and he only presents this dysphagia and this important asymmetry in the cervical region. And in the imaging study, they found multiple lesions, predominantly in the base of the tongue, well circumscribed. And they found 10 different lesions. All of them were consistent with a rhabdomyoma adult type. This was very interesting because this lesion usually because of the embryology the most frequent location is in the head and neck area, but in our case it's different. The presentation is in the chest wall and in distal extremities. So As a conclusion for this case, it's very rare multifocal adultite rhabdomyomas, and there is no known link between this syndrome and these multifocal rhabdomyomas. At least there is no case report. And because of the overexpression of the TP53, it's unknown if this may be confer a potential for an aggressive behavior. So this is the second case. This is a 30-year-old male with the only data available was that it was an orbital tumor. So with this information, we must consider three possibilities. The first one is that maybe this is a primary tumor because we have the optic nerve, the adipose tissue, and extraocular muscles. And another possibility for this location is a direct extension from adjacent structures. For example, the eye, the conjunctiva, the lacrimal glands. And the last possibility is about the metastatic tumor. But in this case, the age is not the most frequent that we must think. Histological sections show these encapsulated neoplasms grow disposed in this solid growth pattern. And these are mixed with these small buzzers of different sizes. Some of them are more large. And the morphology, we can see that these cells are small, with indistinct cytoplasm borders, and there are maybe some disposed to the periphery of these vessels, giving this aspect of myoparasitoid or peritial cells. And in these other areas, this tumor exhibit a more prominent vasculature. We can see these capillaries very thin, and the erythrocyte with blood inside. At lower magnification, these cells are polygonal with this dense eosinophilic cytoplasm. And the nuclei is oval, round. We can see some hyperchromatic nuclei, but no mitosis or no necrosis were identified. Fortunately, we were able to obtain the imaging study, and we can observe this intraconal lesion that is occupying all the orbital cavity and causing this secondary proptosis. And well, we must consider many tumors. One of them is a domus tumor, and this is usually located in distal extremities of the subungual region. But there are a few cases reported in the eye, maybe with an extension of the intraconal area. And these tumors are composed by globus cells, vasculature, and small muscle cells. These tumors express are positive for SMA and GUZMAN. This is a good possibility, but another one is a myoparasitoma. Actually, the most frequent location of this tumor is and the dermis, but rarely can be affect the orbit region. This lesion actually is composed of these mild spindle cells with this prominent vasculature, so we can maybe have some features similar to your case. And this entity is positive for SMA and GUZMAN, but negative for desmin. Another possibility, given the location and the patient is young, is an hemangioblastoma. Well, the most frequent location is in the cerebellum, but another unusual locations are the retina and the optic nerve. And it's composed by two types of cells, the stromal cells and these abundant capillary-sized vascular channels. But I think in this case, it's not the best possibility because the cytoplasm is highly characteristic with this aspect. And this entity is positive for aquaporin and brachyurin, but negative for EMA, GFAP, and cytokeratins. Another possibility is a meningioma. This actually is it's not the most frequent location, but it can be affect the orbital area. And when this location presents in this tumor, the most frequent subtype is the transitional. And well, some meningiomas can maybe express some angiomatoid features, and it's a primary location because it originates from the precursors in the optic nerve. This entity is positive for EMA, somatostatin receptor type 2, and progesterone receptor, but negative for GLUT1, GFAP, and F100. Another possibility is a perineuroma. Actually, it's extremely rare in orbit, but this lesion commonly affects the hedonic region area, and it can be affect maybe these adjacent tissues. We have two subtypes, the intraneural and the extraneural, and well, this entity, I mentioned this because can share maybe some histological features similar to the meningioma. And the immunohistochemical expression is positive for EMA, Claudin-1, and GLUT1. So with these features, the immunohistochemical panel was performed. This entity was negative for cytokeratins, negative for CD34, so we can exclude the possibility of vascular tumor. And also is negative for melanocytic markers like HB45 and S100. And another possibility is was excluded because of the GFAP, like the aim because of the certainty of the analgesic structures. This entity was positive for calculin, but also for EMA. So that's why we decide to perform the ultrastructural studies. So even the artifacts are prominent, we can see these large polygonal cells with these core processes very prominent. And in some areas, we can see these well-developed desmosomal junctions and with some collagen fibers. So these findings are highly suggestive of a meningioma. And given the morphology with low grade, it was categorized as WHO grade 1. And because of the possibility of perineuroma, because these two entities and can be expressed in EMA. We added the good one, which was negative, and the progesterone receptor. So this is an interesting study. The Dr. Abbas-Laigani, and he compares these two entities, the perineuromas and the meningiomas. And the importance of this is that they can maybe share several histological features. This is an example of a perineuroma, and this is a meningioma. And he proposed this 5-marker panel of immunomarkers. Given these two entities can express EMA, it doesn't going to help. But for meningioma cases, these are highly positive for somatostatin type 2 receptors and also for progesterone receptors. And for the perineuroma, these are positive for Claudin 1 and GUD1. So, as I previously said, the EMA, it doesn't help to distinguish between these two entities. But if we have a case where we have this probable confusion, we can be support in the expression of somatostatin type 2 receptor and progesterone receptor. And in cases when the immunohistochemical markers are not conclusive, it's recommended to perform an ultrastructural analysis. This is another article that explains the clinical, radiological, and pathological findings about meningiomas in this location in the spinal orbital. And they found that the most frequent gender effect in general was female of 40s, but this group of pediatric was also included, and this is a very rare entity. Actually, it represents less than 5% of all the cases. This is another article about meningiomas in pediatric patients, but this article included two types of meningiomas: the sporadics and the associated with neurofibromatosis type 2. So it emphasized in the principal difference between these two entities. Because the meningiomas are about 38% of all the primary central nervous system tumors, but in pediatrics are least frequent. And I found something very interesting. The most of the cases were for sporadic cases, and these ones are more associated with this sporadic variant. But the unusual location, like the optic nerve, actually was more associated with patients of NF2 syndrome. So I think this is overlap. But as the conclusions, the median age is actually very similar in the sporadic cases of NF2 associated, but they found that this tumor, the patient who present multiple lesions are more frequent associated with NF2, unlike the sporadic cases. And the most frequent location in the NF2 was the optic nerve and in the intraorbital. Unfortunately, we were not able to confirm, we don't know the NF2 status in this patient, but it will be very interesting to know if this was a carrier of this syndrome. This is the third case. This is a 50-year-old man with supraclavicular cervical lymphadenopathies and dyspnea. This was the only data available at the moment that we received this material. This was a second opinion consultation, and we can observe that the total effacement of the lymph node and is replaced by this malignant lesion with these epithelioid features. At higher magnification, the cells are polygonal with this dense cytoplasm and this appearance, this epithelial appearance, and alternated with these extensive necrosis areas. In this other picture, we can see the dysmorphagia is more present. And on the higher magnification, we can observe the pleomorphism and the high-grade mitotic activity, and maybe a focal glandular differentiation. So our first diagnosis without perform the immunohistochemical markers was a metastatic carcinoma of unknown primary, and we decided to abort this tumor like that. That's why we performed cytokeratins and was positive for CCA7 but negative for CCA20. And given the symptoms of the dyspnea, we emphasized in rule out leukodenocarcinoma. We performed NAPSID-A and TTF1, which were negative. And also, we decided to perform these two mesothelial markers, carrageenan and podopterin, both also were negative. So to this point, we had a lot of possibilities because of an unknown primary, like cholangiocarcinoma, like a thyroid. So we decided to reevaluate the imaging study. So we can observe these bilateral lymphadenopathies causing this displacement of the trachea. And also, we identify these lesion lymphadenopathies in the mediastinal area, and this lobulate tumor predominant affected the right lobes. So the radiologists conclude that this was highly suggestive of a leukodenocarcinoma or a mesothelioma, but we already performed immunohistochemical markers, so that's why we decided to add more markers. In this case, we performed cytokeratins 5 and 6. But it was negative. And the WT1 was maybe focally in some of these nuclei, but non-conclusive for an mesothelioma. That's why we decided to perform the ultrastructural study. Well, in this large cell, we can observe at the cell surface these large and densely packed microviolence in direct contact with these collagen fibers, and maybe these findings were consistent with a mesothelioma. We added the last mesothelial marker, the GATA3, and was the only actually which was positive. So finally, we can conclude that This was a metastatic epithelial mesothelioma in the cervical lymph node. So for the literature review, actually, it's very rare that the malignant mesotheliomas present like an initial manifestation in lymph nodes. And this is an article about the pathological and clinical manifestation of this entity. And this was performed, this malignant mesothelioma was initially diagnosed in lymph node biopsy. The locations of these biopsies was supraclavicular, axillary, cervical, mediastinal, and all the patients present polyserosities. Some of them present cold expectoration, but all these cases present 2 or more mesothelial markers. So they conclude that there is practically no much case reports about this initial presentation of the mesotheliomas, because the most of the time the patients had already present another symptoms, and they recommended that we must be careful, because in cases where this epithelial appearance is very prominent, we can be confused because it can be mimic metastatic carcinoma. So that's why they recommend that to perform a correlation, if it's possible, with the imaging studies and immunohistochemical or all the data available. This is the case this is a 70-year-old male with a history of poorly differentiated carcinoma. This diagnosis was performed in an external institute and was 8 months ago. The actual clinical stage, or the clinical suspect, that this patient presents a probable abdominal wall soft tissue involvement. This is the current imaging study, and we can observe this mass with these infiltrating edges, with this diffuse thickening of this abdominal wall, maybe. And we receive this specimen. We can see the adipose tissue that is alternating with these fibrous areas, with an increased consistency. But at the sections, without these neoplasms, with these glandular appearance exposed in these patterns, and at higher magnification, it presents the cilia on the surface, in the luminal part, and with some glandular appearance. So, because of these histological discrepancies between the initial biopsy of the GUZMAN biopsy and with this specimen, we decide to review the previous biopsy. And we can observe at the section that the gastric mucosa is completely intact, and adjacent these neoplastic cells are infiltrating, and at higher magnification show this apparently this discoisive pattern, but some of them are very like joint. This was the only immunomarker available for this case, were cytokeratins, and this was the previous report, a poorly differentiated adenocarcinoma. We were also able to obtain the previous imaging study, and we can observe this diffuse thickening of all the gastric wall. In the luminal portion is the nasogastrical tube. And the report of the endoscopy mentioned a lesion consistent with the Borman 4 limnitis plastica. So that's why we decide to complete the immunohistochemical marker in the initial biopsy and also to perform the ultrastructural study. So here we can observe these polygonal large cells with this enlargement of the extracellular space. And in the surface, we can observe this microviolet lacking of the curved rollets. So, well, these findings were highly consistent with mesothelioma. And in the abdominal wall specimen, we complete the immunohistochemical marker. This was negative for calretinin, but positive for the rest of mesothelial markers like WT1, CK7, CK90, 5-6, and also was positive for thrombomodulin. Well, in the initial gastric biopsy, we also performed the same immunomarkers, but we added some others. In this case, we added cytokeratin 20, CA, some MOX, and this is because we want to demonstrate that a gastric adenocarcinoma was not an option. Unfortunately, the patient was deceased, so the clinical were not able to complete another imaging studies just to confirm that the only location was in the peritoneum. So that's why the final diagnosis impression of this case was about a malignant peritoneal mesothelioma with second involvement to the gastric wall. This entity is very rare, actually represents about 10% of all the mesotheliomas. It's still associated with asbestos exposure. And clinically, we have two types, the diffuse and the localized. The problem with this particular tumor is that there is many overlapping in imaging studies or even in the histological features. So that's why sometimes it's very complicated to perform an adequate diagnosis previous to the surgery. This is another article, and they present a 60-year-old man with ascites. And the imaging study shows this gastric this diffuse thickening of the gastric wall. They found also gastric lymphadenopathies, and they found this diffuse thickening of the peritoneum. And well, the problem with this in this case was that the initial biopsy was non-diagnosis. And the endoscopy reports a multiple gastric erosions. And the first consideration was diffuse type gastric adenocarcinoma. Fortunately, the pathology department received these three specimens at the same time. In the gastric biopsy, we can observe these fully differentiated neoplasms with these epithelial features between these normal glandulars, but in the peritoneal effusion, the findings were different. And we can see these cells are very suspicious for mesothelioma. In the peritoneal biopsy, they found these neoplasms with similar characteristics, but these gland appearances were more prominent. That's why they decide to perform two immunomarkers, two mesothelial markers, carrageenan and cytokeratins 5 and 6, which was all positive. And to rule out the possibility of a gastric carcinoma, they also performed B72.3 and CEA, both negative. That's why the final diagnosis was a primary peritoneal epithelial mesothelioma with extension to the gastric wall. It's a very rare entity. This is another article, but this is about a 50-year-old man with abdominal tape and mass. The imaging study shows a lesion that apparently depends in the colonic mesentery, and that's why the initial diagnosis impression of the clinical was for a GIST or for a liposarcoma. They decided to perform a subtotal gastrectomy and right hemicolectomy. And this was the specimen. We can see that the most part of the tumor is in the mesenterium, but it's also infiltrating all the wall of the colon, and is pushing the normal mucosa in the stomach wall. The morphology shows epithelioid neoplasm with this solid growth pattern, and they decided to perform three mesothelial markers. Was positive for carrageenan, WT1, and cytokeratins 5 and 6. So to perform this diagnosis is very complicated because there is no specific clinical presentation. We must rule out other entities before to make this diagnosis. And another contract is the overlapping of the imaging studies. And in the most of the cases, the preparative biopsies were non-specific or inconclusive. That's why they recommend to correlate with the imaging study and with immunohistochemical markers.
Thank you very much, Dr. Chan. Yes, beautiful cases. I would add to this last paper that the gold standard for the mesothelioma diagnosis is still electron microscopy. So I would recommend that. This is the last two cases I'm going to present by myself. I try to be quick because the time is running out. This is a 30-year-old man with initial symptoms of pain in the middle right foot, not associated with trauma, and the symptoms quickly increased in 10 weeks. On the physical examination, 2 exophytic ulcerated lesions in the first and fourth toes, and ulcer-like lesions, and no lymphadenopathy. These are the initial image studies, and it was a generalized decrease in osseous bone density, and many tumors located in the astragalus, scaphoid, cuneiform, talus, and toes. And with this arrow, there's a lytic lesion, which is also on the phalanx. And here are lateral projections of the same bone lesions. And in T2, the MRI was brilliant. And this is the histology. The histology is of a rhabdoid lesion. The cells are large with ample cytoplasm and has a rhabdoid appearance. Another one, the same appearance. They were positive for vimentin, cytokeratin, ERG, and CD31. The INI1 was preserved, CD34 was negative, and this new antibody, OSB, was positive. This is the summary of the immunohistochemistry. It was ERG, positive, CD31, CK7, vimentin was preserved, the INI1, and phosphate was positive. It was negative for melanocytic markers, for other cytokeratins, for EMA, actin, and P53. The electron microscopy, I can't think that this is the first one, the first time the electron microscopy is done in this type of tumor. It was ample cytoplasm, rich in intermediate filaments, and these rods, which are Weber-Palade rods. These are illustrated better here. And this is a new entity called pseudomyogenic hemangioendothelioma. It's a relatively new entity. It was described in the 90s by the Mayo Clinic people. It's affected young adults, multifocal, bone, and only one of this series of cases, were more than 20, it was metastatic. They propose that it's a variant of the epithelial sarcoma. And they propose the term fibromatous, fibrohistiocytic myeloid variant of epithelial sarcoma. This is from the article, and this is another one written by the Mayo Clinic people in 2003. Dr. Weiss is there also. This describes a similar lesion, predominantly epithelioid in non-metastatic, with endothelial differentiation by immunohistochemistry. And they propose this term, which I think is the best term, but it's not the accepted one at the moment. They proposed the term epithelioid sarcoma-like hemangioendothelium. Until 1911, these people from East Coast, Dr. Horlick and Fletcher, described 50 cases, predominantly males, young male, 78 in the extremities, predominantly inferior, multifocal, and affected several planes of the same extremity. Can affect skin, subcutaneous tissue, bone, can be the muscle, and only one of these patients, these 50 patients, developed metastasis. They proposed the term pseudomyogenic hemangioendothelioma, which is the one accepted by the WHO. This has the illustration of the original article. It's the same histology. It looks like a epithelioid sarcoma, and the marker, the immunohistochemistry marker, is FOSB, and it has to be differentiated from epithelioid hemangiothelioma, which is positive for CD34, and this is negative. And this has the CANTA-free instead of FOSB. The epithelioid angiosarcoma is a malignant tumor and is not positive for these two antibodies. And the epithelioid sarcoma has to be the INI1 suppression present. Quickly, I'm going to go through the differential diagnosis. The epithelioid sarcoma looks like a granuloma, here also with central necrosis. Here with look like histiocytic cells with central necrosis, and the proximal variant has this rhabdoid appearance, and is very aggressive. And here are some illustrations. The structure of the epithelioid sarcoma has intermediate filaments forming a paranuclear ball with a replacement or pushing the nucleus. The hemangioendothelioma has this appearance. The epithelioid hemangioendothelioma has a myxoid background with lumina. Histologically has this appearance, myxoid. It has to have at least one endothelial marker and one epithelial marker. The angiosarcoma, the epithelioid angiosarcoma, has atypia, frank atypia, and marks with both CD31 and CD34. Genetically is very complex and do not mark with the FOSB. Conclusion, the case I presented, pseudomyogenic hemangioendothelioma, is a rare tumor, probably is confused with other tumors, affects several planes, has a rhabdoid morphology, has negative for CD34, but positive for CD31, ERK, keratin, and FOSB. And this is the fusions, terpene phosphine. It's a novel finding because there are no studies on this type of tumors, no structural studies. It has abundant the wider palate bodies, rods, and has the intermediate filaments. This is the differential diagnosis I went through. This is the last case. It's a 31-year-old male. Yeah. Okay. With a headache and neurologic symptoms. It has, on this image, has a central or paracentral located lesion. Here is also attached to dura, the cerebral falx, and is hyper intense on T2. It has this appearance. The cells are polygonal and has many hypercellular areas with rounded cells, smaller, and on a sarcomatoid. Well, these are ample cytoplasm, and these are small. So the diagnosis was here meningioma in the first place because it's attached to the dura, but has these small cells. And many mitotic fibers, 1, 2, 3 here, 4 in this field, which is high power field. And here it has 5 mitosis. So this is a malignant tumor. Malignant has no much pleomorphism, but has the small cells, polygonal. EMA was negative, so we rule out melanoma, meningioma, and we did CD20 to see if it was not metastatic tumor. And before that, we performed the S100, which was positive, so that we thought it was a melanoma. We were allowed with SOX10 and HMB45 and Melana. It was positive for CD68. For CD163, 100, CD18 was a positive. Langerie, and K67. So this is a Langerhans sarcoma. We complemented, this is not diagnosis, but we did the electron microscopy just for fun to see how it looks like. So the RAF was negative. These are frequently positive. And this is paraffin fixed tissue, is not wet tissue. So you can see these cells, which are polygonal cells with a groove in the center. Here less grooved, elongated nucleus, but not the typical Langerhans cell. But we have to remember this is a sarcoma, so it loses some of the ultrastructural characteristics. And here are the Berwick's granules. Here. And here, coming from out of the membrane, is a beautiful Berwick granule. This is another case. This Langerhans histiocytosis to compare. This is a beautiful Wilbur cow body, but it's also as preserved as the other one. Here are the summary of what I show you about the immunohistochemistry. Even with the WHO divides or separates Langerhans histiocytosis from Langerhans cell sarcoma, it's a spectrum that begins with the benign, long-standing, and the malignant. It's more common in several other organs, but few in the nervous system, and especially very few cases in the meninges. And the meninges is the Rosai-Dorfman disease more prevalent than the Langerhans cells. It almost always affects the brain. This is from the literature to see the central nervous system affections. Can be de novo or in association with hematological diseases. It's very aggressive neoplasm and no treatment for that entity. It's a combination of histological findings and immunohistochemistry, but the Berwick granules are pathognomonic almost. The differential diagnosis I mentioned, meningioma, melanoma, is histiocytosis because it has to have atypia with a histocytic sarcoma, which is negative for these two antibodies, and lymphoma. Conclusions is that Langerhans sarcoma rarely affects central nervous system, especially meninges. It's very difficult to establish by image studies. It's important to recognize the nuclear features, but can be lost in Langerhans sarcoma. The expression of CD1A and CD207 is essential, but the pathognomonic structure seen by electron microscopy is the Berwick. Thank you. Well, that was just a few examples how the fine outer structure can be preserved, or sometimes it's not as well preserved. I should recognize, but it is possible to have a good preservation and make diagnosis, and especially make correlative studies of molecules or whatever with electron microscopy. Unfortunately, is my impression that every time as the time is passing, less hospitals have an electron microscopy, which is expensive. But if we have one and we have the lab, why not use it? Thank you very much.